This episode is brought to you by... Oops, I've got a box of Cheez-It crackers staring at me and I just wanted that irresistible cheesy crunch. Sorry, that was a total snacksident. What was I supposed to be talking about? So salty, so crunchy, so cheesy. Whoops, lost my train of thought. I've heard of brain freeze, but brain cheese? I'll just have one more Cheez-It cracker and then I'll get back to it.
Meet the computer you can talk to. With Copilot on Windows, working, creating, and collaborating is as easy as talking. Got writer's block? Share your screen with Copilot Vision to help spark inspiration, and use Copilot Voice to have a conversation and brainstorm ideas. Or maybe you need some tech help. With Copilot Vision, Copilot sees what you see. Let Copilot talk you through step-by-step guidance so you can master new apps, games, and skills faster. Try now at windows.com/Copilot.
Hi, and welcome to the Med Prep to Go USMLE Step 2 podcast. I'm Dr. Raj, quadruple board certified doctor in pulmonary, critical care, sleep medicine, and internal medicine. And I've been doing this for over 20 years, meaning educating people, teaching USMLE Step 1, 2, and 3. Teaching is my passion and my jam. So this is I think it's one of my first podcasts for USMLE Step 2. I'm so excited. So let me just tell you our mission statement. Our mission statement is to improve medical student wellness and reduce educational debt by providing high-quality USMLE question bank in an online and audio format. Also, by making medical education material available to study on the go. We, meaning me and my wonderful partners and team members, strive to give you time back in your day to focus on your health and well-being. So what do? We actually will read 3 questions from our website. And today's, I was thinking about it. Let's do pulmonary. Why not do my favorite thing in the whole world? And we'll read 3 questions. And like I said, come check out our website, look at the questions, and we'll go from there. So our first question is going to be: a 45-year-old overweight man with no medical history is referred to you for the evaluation of obstructive sleep apnea. Stop right there. Is being overweight and obese a necessary feature for OSA? The answer is no. Because where is the obstruction, everyone? Is it in the abdomen? And the answer is no. It's in the back of the mouth. It's the posterior pharynx. What size is your tongue? How big is your uvula? Do you have tonsils? Do you have a high arched palate? Do you have micrognathia? Wait a minute. I totally forgot. I'm reading a question. So anyways, he's overweight. He complains of loud snoring, excessive daytime sleepiness. Physical exam is unremarkable, except for a BMI of 29. And he does have a crowded oropharynx. His primary care physician ordered a home sleep study that demonstrated mild OSA. The apnea-hypopnea index is 12. So from 0 to 5, AHI is normal. 5 to 15 is mild. And 15 to 30 is moderate. Anything above 30 is severe. Back to the question, his AHI is the mild amount. They treated him with CPAP with a nasal mask, and the patient could not tolerate CPAP despite multiple mask changes, CPAP device adjustment, educational interventions. So they're really trying him to, use the mask, get used to the mask, adapt to the mask. But you know what, everyone? This is not surprising. The patient wants to pursue treatment for his OSA, but cannot tolerate having a mask on his face. In fact, he finds CPAP more disruptive to his sleep. And I got to tell you, stop right there. Being a sleep specialist, I see this all the time. That's why you have to know what is driving the symptoms. I mean, is it truly the mild OSA driving symptoms? Is it really insomnia? But there are people with mild OSA that need to be treated, whether it be because of cardiovascular disease, such as atrial fibrillation, heart failure, maybe underlying pulmonary disease. But I'm forgetting we're reading this question. So in this individual, 45-year-old guy, mild obstructive sleep apnea, AHI of 12 once again, can't tolerate the mask. What is the next appropriate recommendation? Is it A, evaluation by sleep dentistry for a mandibular advancement device? B, continuing CPAP with the addition of a sleeping aid such as zolpidem? Is it C, return to the otolaryngologist? Oh, for a hypoglossal nerve stimulator evaluation. Oh boy. All right. That sounds like something brand name called the Inspire device. D, stop treatment since the HI is less than 15 and it's considered mild. Oh, maybe a little tempting, but he is having some daytime symptoms, I believe. Or E, try a new modern sleep hack that has gained recent popularity called mouth taping. I don't want to be, tell you the answer, but I'll tell you one thing. It's not going to be try mouth taping. So what seems to be the right answer here? The answer is A, evaluation by sleep dentistry for a mandibular advancement device. So a couple things, you know what I mean? Multiple trials have shown that treatment of mild OSA does improve daytime symptoms and quality of life. And going back to that question, he says excessive daytime fatigue and sleepiness. If he was truly, truly asymptomatic, I don't think I would have treated this person. He has no comorbidities. But because of that, yes, I think treatment is important. When we talk about these oral appliances, the mandibular advancement device, and I got to tell you, please, this is not one of those flag football boil and bites. I mean, this is something you want to go to a board certified dentist who's board certified, hopefully in sleep medicine. And there are many different brand names out there. And usually there are two pieces, one for the lower jaw, one for the upper. And you slowly titrate the lower jaw to move forward. And by doing that, it opens up the airway, it moves the tongue forward. So it does help out. And once again, this is mandibular advancement devices used for mild to moderate OSA. Do these devices have side effects? Of course. Things like TMJ, so you definitely want to be careful. And also, if you're going to use this mandibular advancement device, you want to make sure that they have teeth. We don't use these devices for central sleep apnea at all. You don't use for these devices for people who are hypoxic on top of their apneas. So, of course, in this case, this is definitely the best thing to do. But let's talk about the other ones. The hypoglossal nerve stimulator, brand name Inspire, is approved for patients who have moderate to severe OSA. And these individuals, if you want to use this hypoglossal nerve stimulator, let me describe it, that it's a implantable device, usually goes on the right chest. We save the left chest for the pacemaker. And there are two wires. One is going to connect to the hypoglossal nerve that innervates the tongue. So it actually, every time the patient breathes, it causes the tongue to actually go forward to open up the airway. And the other lead actually connects to the chest wall. There are very specific criteria. There's definitely going to be age criteria, BMI criteria. You want to make sure that the AHI is not too high. And this criteria is actually not becoming as stringent as before based on newer data. But you do need to undergo something called a drug-induced sleep endoscopy, which is a procedure where you go in the inpatient. It's an outpatient procedure, but they will make you sleep, whether they give you some midazolam or they give you some propofol. And when you sleep, they put a fiber optic scope through the nose and they look at the collapse of the upper airway. And you really want a specific upper airway collapse called anterior posterior. And those are the individuals that will really benefit from this hypoglossal nerve stimulator. And once again, to get this, you probably have to fail CPAP first. You definitely want to be teamed up with an otolaryngologist, ENT doctor who's very familiar with this. But this wouldn't be this case over here. This is mild OSA. This is going to be something that would definitely benefit from a mandibular advancement device. Couple of other things. I wouldn't stop the treatment D because the patient is having symptoms of excessive daytime sleepiness. Continuing CPAP with the addition of a sleep aid such as zolpidem, don't get me wrong. There is some data that you could use a sleep aid. The one they used in the studies was called isoprolol, brand name Lunesta. That they would use for around 14 days. Why? To help you get used to the wearing a mask. That's not going to be in this case over here. You know what? This is someone who has already tried multiple times. The studies that I was referring to were done immediately up front when they first got the CPAP device. And the new modern sleep hack of taping your mouth, I just in case anyone who's listening is a big TikTok fan, I don't want to, badmouth, mouth taping, but the truth is that, you always have to ask the question, why are you taping the mouth? Is it for snoring? And remember, if you're taping it for snoring, you better make sure they don't have obstructive sleep apnea, because taping your mouth is not going to address that. And also what worries me is once if someone, has nasal polyps, once if someone has a deviated septum, then on top of that, you tape their mouth shut, that's not going to do good. But of course, we are meant to be nasal breathers, breathing through the nose definitely humidifies the air nicely. You have the cilia that's actually going to try to, filter the air nicely for us. So I do think nasal breathing is important, but I definitely wouldn't mouth tape. I do not promote mouth taping. And anytime someone snores, you must evaluate to make sure they don't have obstructive sleep apnea. So what is the learning point here is for patients with mild to moderate OSA, dental appliances such as the mandibular advancement device will actually move the lower jaw forward. It helps the tongue to be pulled forward. And these are going to be devices that will be very helpful in these select individuals. All right. That was a good one. Let's do another one. Question number 2. We have a 65-year-old man with metastatic bone cancer comes to the emergency department due to difficulty breathing. He's been taking a short-acting opioid every 6 hours for bone pain with minimal relief. He noticed an increased work of breathing starting in the morning after eating breakfast. Vital signs are 110/60. Heart rate is super tacky at 124. Respiratory rate is tachypnic at 25. O2 sat is 89% on room air. On exam, the patient appears to be uncomfortable, slightly dyspneic, and at times lethargic. Heart sounds are normal, and the lungs are clear to auscultation with adequate symmetrical chest rise. A portable chest X-ray reveals unremarkable findings, except for some mild basilar atelectasis. They do an ECG. It shows sinus tachycardia with a right bundle branch block, but there's no previous ECGs that were available. What should be the next step in the evaluation of this patient? So what are going to be the choices over here? Is it A, increase the opioid dose and consider IV administration? Is it B, discontinue the opioid and start tramadol instead? Is it going to be C, is it going to be order a D-dimer and VQ scan? Is it D, perform a CT angio? And if the patient has adequate EGFR, or is it E, bedside spirometry? So I'm looking at these choices over here. And, when I think of A, this is a patient with metastatic bone cancer. A patient is going to be in pain. Of course, you always worry about giving too many opioids because of the fact that if patients start becoming lethargic, they start, increasing the CO2. And I see some of that over here. So, of course, this is something you definitely want to evaluate because of the fact that the patient is going to be lethargic. And with that being said, you definitely want to get that arterial blood gas, which is not going to be in the question. But I do like that. But what, choice A says increase the opioids. So I don't think that would be my first thing to do is increase it if I'm worried about him being lethargic and an elevated CO2. And of course, if the patient's tolerating oral, I wouldn't go for IV. So I'm not picking A there. B, discontinue the opioid. Well, I think that's a very strong thing to say, is just discontinue. But why did they put tramadol? Tramadol is a partial opioid, agonist. And it is a good medium if you want to start downgrading, from an opioid to tramadol. But I think you're not addressing the next step in evaluation of this patient. Why is the patient going to be hypoxic? Why are they going to be tachypnic? So it just doesn't answer what's going on. So I'm not saying no, you know what I mean? But the question is, next step in evaluation of a patient appears uncomfortable, slightly dyspneic, and at times lethargic. So it's not increase the opioid. It's not B, discontinue the opioid and start tramadol. C, order a D-dimer and a VQ scan. It really depends upon your pretest probability. And someone, who has known cancer, that's such a high risk for developing something like a PE. They're hypoxic, they're tachypnic, they're tachycardic. So those aspects of everything definitely is something that says they're going to be at a higher risk. So I'm not going to put, D-dimer. And if they could do a CT angio, I don't think I'm going to mess around with the VQ scan. Choice D, perform a CT angio looking for pulmonary embolism and given some contrast, which you need to do, assuming they have an adequate estimated GFR. I love that. So that one seems very reasonable. E, bedside spirometry. Are you kidding me? Patients like tachypnic and hypoxic. Don't be a mean person. Don't make them do spirometry right now. So the right answer here is definitely going to be what? D. And looking at the answer, it just says, got an older patient, metastatic bone cancer, malignancy is so high as a risk factor. I will say that it's not wrong to look for a pulmonary embolism in this case, but at the same time, I'm going to give you some add-on pearls. You want to make sure this patient isn't what? Hypercapnic, and if they're hypercapnic, well, how lethargic are they? Maybe you could put a little bi-level to blow off the CO2. And if they're really becoming hypercapnic and you have pain, we need to address the pain better. But based upon this question, I do think that the right answer here is D. What the vitals look good for it, the hypoxia, but definitely remember, everyone, get that ABG to evaluate hypercapnia. All right. That was a good one. Let's do one more. Hang on. Let's see. Here we go.
This episode is brought to you by Marqeta. When it comes to your payments provider, you can't afford to compromise. Marqeta's modern payment solutions flex with your business without the trade-offs. Stable and agile, secure and innovative, scalable and configurable. If they say you can't have it all, don't believe them. Your business demands more. Choose a payments provider that delivers more. Choose Marqeta. Visit marqeta.com/Spotify to learn more.
Vitamin Water Zero Sugar has great taste, zero BS, and obviously zero sugar. For those with zero room in their calendar, zero patience for slow walkers, those who get 0 hours of sleep on a Saturday night, have zero filter, zero given, and zero interest in grabbing a plain, boring water. Grab a delicious Vitamin Water Zero Sugar today.
And the last one is going to be, I'm really getting into this. I'm just supposed to read the questions, and I'm like throwing out all these pearls. All right. How about 65-year-old woman comes to the urgent care facility for worsening fatigue and dyspnea on exertion. She has been experiencing this for the past 2 to 3 months of unclear etiology. She was recently diagnosed with osteoarthritis of the hip and is taking over-the-counter Tylenol and ibuprofen with minimal relief. She has a 15-pack-year history of smoking, but quit about 20 years ago. Recent cardiac workup ordered by her primary care physician included an ECG and echocardiogram. Both were unremarkable. She had an unremarkable recent chest x-ray, a full PFT that showed an FEV1 FVC ratio of 80% predicted, an FEV1 of 84% predicted, FVC of 90% predicted. No significant bronchodilator response was noted after they administered albuterol. TLC was 88% predicted, and the DLCO was 68% predictive. CBC is ordered and results are pending. What could be the cause of her symptoms? And we have a couple choices that we're going to be going over here. Number one, Is it going to be emphysema? Now, when I think about emphysema, what part of the PFT is going to indicate obstructive lung disease? Yeah, it's an FEV1 FVC ratio less than 70% predicted. What is the FEV1 FVC in this case? Yeah, it's 80. So by definition, I'm going to say that this doesn't meet the obstructive lung pattern, so emphysema will be taken off my list. Let me switch to choice C, interstitial lung disease, such as idiopathic pulmonary fibrosis. Well, strictly looking at the PFTs, it would have a restricted pattern. And the one PFT parameter that defines the disease as restrictive is the TLC being low. The TLC was normal, 88. So I'm really not going to do that. And she had an unremarkable chest x-ray, which takes pretty much this interstitial lung disease off the table, pretty much emphysema off the table. Then the next one is pulmonary arterial hypertension. Now, stop right there. That's not a bad choice, because when I think of pulmonary arterial hypertension, you have a normal spirometry, which we have there. The ratio is normal, FEV1 is normal, FVC is normal. You have a normal lung volume, so the TLC being normal, but you would get an isolatedly low DLCO in pulmonary arterial hypertension. So I like choice D quite a bit. So I'm not taking it off yet. It kind of fits it. E, chronic bronchitis, you'd kind of assume more of that, obstructive lung pattern. So we'll take that off anyways. But what really takes PAH off the table has got to be one thing. They had a recent echo. If the echo wasn't done, then I would say, okay, PH could definitely be the answer. But because they had a recent echo, and what do we look for in a transthoracic echo? We look for a right ventricular systolic pressure greater than 40 millimeters of mercury. And that would indicate possibly pulmonary arterial hypertension. Of course, you confirm it with a right-sided heart cath. But yeah, you know what the right answer here is? I like this question. It's B. B as in boy, iron deficiency anemia. So why is that? Because when you do the DLCO, you're giving carbon monoxide through the mouthpiece. They're inhaling it. Who picks up the carbon monoxide in the capillary? It's hemoglobin. And hemoglobin loves carbon monoxide. But if you're anemic, regardless of the cause of anemia, you have what? Less RBCs. RBCs carry what? Hemoglobin. So if there's less hemoglobin, yeah, the DLCO is going to be falsely what? Low. So the answer here is going to be B. I feel this is going to be a great question for your USMLE Step 2, combining some basic science, pulmonary. And those are the 3 questions for today. I know I went above and beyond and started talking about all these different things, and I hope you find it useful. And please follow me on social media. And for all the questions and reading the questions, go to the medprep2go.com website. And thank you very much. And I'll be seeing you again for our next set of questions.